Thank you, Dr. Hassel, for the kind introduction. And here I just try to kind remind everybody if you have the time to just complete the module and take the final midterm or final exam, so we can have um, just document it. You have done those. Right. So today I'm just giving a summary of this area. Cervical screening is a WHO goal. You're probably already aware WHO their aim at 2030 to just decrease the cervical cancer worldwide. So today I'm focused on squamous lesion. So this is a slide showing in USA itself. Probably 50 to 30 years ago, before we more than that, since 1950 we started HPV screening. At the pap screening, we have a decreased cervical cancer. Now you can see the cervical cancer is on the 22nd, before is within the top 10 the cancer incidence. So today's project I'm going to go over is cervical cancer and the HPV testing, and what is the screening and management guideline after that, and HPV vaccination in US. And we have assessed the system as a standardized reporting system, and some, diagnostic challenge and pitfalls in squamous lesion. So I'm going to start with HPV and squamous epithelial lesion. On the left-hand side, you can see HPV is the cause for, almost like 90 to 100% of squamous lesion. And you have, if you have HPV infection, the first you get, transient infection, and it can appear as a low CO, but it can clear it up by itself. But if you have persistent HPV infection, then it progresses to high-grade lesion we call high CO, that's precancerous lesion. And eventually, if you don't get caught early stage, then it progresses to cancer. So as I mentioned, in 1950, Dr. George Papadopoulos to invent this pap test, and it started very widely accepted in US. At that time, had this pap test has very good specificity, but the sensitivity is not as good as HPV test. I will show you the slides, and you can see at the beginning the aim is the more you screen, the sensitivity will increase. So this is the study, multi-center study to look at pap testing. What the sensitivity is variable, but it's not that great. It's from 44 to 74%. In contrast, later on, the high-risk HPV testing get introduced. The sensitivity increased dramatically. It's over 90% sensitivity for CIN3, and that CIN3 is what we try to catch it before it become cancer. And in the other side, if HPV testing is negative, you can tell from this graph. The green color, if HPV negative, the incidence, the cumulative incidence of CIN3 is really low. So high-risk HPV testing, what we use currently in US, so there's a couple ways. One is reflex testing on ASCUS, and we'll do the reflex on ASCUS and genotype and for the HPV, either 16, 18, or others. And another way is co-testing. You probably are aware in the module we're talking about that started 30 years old until 65, and primary HPV testing now is on the rising. the American Cancer Society proposed the primary HPV testing from 25 to 65. So currently this is just the rough number. Current application, the HPV testing. As I mentioned, HPV reflex toward ASCUS is about 40%. The co-testing about 60%. Now the HPV priming is on the rise, but it's still like 1%. It's not widely. Like in Europe, they have more primary HPV testing, but we're making effort to do that. So this is hybrid model. What we do, if we use co-testing, so you ordered a PAP test and HPV. If you can see if PAP is negative and is HPV negative, that's routine. But if it's ASCUS or HPV negative is still routine, and if PAP negative, HPV positive, then you do co-testing in 12 months or genotyping. And if you have ASCUS and plus HPV above, then you go to colposcopy. And this is the algorithm for primary HPV testing. If HPV primary testing is 16 or 18 positive, patient go direct to colposcopy. If it's 12, we have different lab have different number, but if it's other than 16 and 18, then you reflex to cytology. And if it's HPV is negative, pretty much you go to routine screening. So the management in US at least, they try to balance what is benefit, what is harm. So, and they propose this theme as a similar management for similar risk. So that's the theme they try to propose. If it's really low risk, if it's lower than 2%, then you repeat the screening. The cutoff line is go to colposcopy is have to be above 10% the risk for CIN3. And if it's the risk is really high, above 40, then have immediate treatment will implement it. So this is again the chart. You can see about 40% risk for CIN3, then you send the patient for either lip or biopsy, further confirm is whatever it's institutional variation is there. So there is a guideline, and again, a current guideline in US, and as I mentioned, a American Cancer Society in 2020 push out the screening guideline as primary HPV test is preferred. And US task force, they're still in the draft, is not finalized. The guideline is they either you can do primary HPV testing, or alternative is co-testing or reflex testing. And ASCCP guideline is either you can, it's depend on the clinician's choice preference, and then you can choose either primary HPV cytology alone or co-testing. And now the self-collection testing is on rise again. So HPV vaccination in US, we pretty much use 9-valent test the vaccination. The bivalent, quadrivalent is out of the game. We, as I mentioned before, we currently use this Bethesda system. The most current is 3rd edition, published in 2014. I think we're in the process to update another 4th edition is on the way. So And this from here on, I'm going to just use the current but assist the system talk about squamous lesions. So adequacy criteria is minimum 5,000 squamous cells for LBP and 8,000 to 12,000 to conventional preparation. I don't know in your country you use it currently use LBP or conventional, so that's the guideline. And 10 endocervical or slash and or squamous plastic cell is just like as a quality check. And so again, this is the Bethesda system. They're talking about different things, adequacy, and also endometrial cell. If it's patient is older than 45, then we mentioned that. And also epithelial abnormality divided squamous and glandular. So I'm just going to focus squamous lesion. So this is the reporting scheme. You get normal and ascus and low seal, high seal, and squamous cell carcinoma. So this is just a chart for the normal. We use intermediate cell as a reference cell, so it's about 35 that size, and then normal is 50. Excuse me, and then you can see ascus is 2.5 or 3 times bigger than the normal, and low seal is 3 times bigger. So with that in mind, and I'll talk about just some normal squamous cell, but it's not. So you can see left-hand upper corner that's superficial, the orange color, and the green color is the intermediate cell. That's the normal size. And on the right upper hand corner is atrophy, appear as hyperchromatic group, but the nuclei memory is very smooth, chromatin is fine. And left lower, that's squamous metaplasia. Just keep that in mind. So ascus, as I mentioned, is a large nuclei, and the most important thing I want to mention that ascus is not a wastebasket for, is you have to rule out everything that is the scenario. If you suspicious is a seal lesion, then but not enough, then you call ascus, and then including ascus, AIC is including ascus and asc-H, which I will talk about. So this is a kind of picture show you there's only single cells have enlarged nuclei and kind of collocytic looking, and you have nuclear contour slightly irregular. So you can call this ascus. And this is again another ascus. You can have double nuclei, but the nuclear contour pretty irregular. But they're rare. And there's another, if you have rare, just one, then you can abnormal ascus squamous cell, you can call ascus. This is one is keratinized ascus. You can see, compare adjacent normal superficial cell, orange color is very large nuclei, but it's not enough to call low seal. So this is a squamous atypical parakeratosis. So, and you can see this nuclei kind of enlarged, but is different from normal parakeratosis. So you have atypical nuclei. And this is another, this is a typical in comparison for the typical parakeratosis in contrast with atypical parakeratosis. So this is atypical repair. Atypical repair, I just want to point it out, can mimic squamous cell carcinoma because the prominent nucleoli, and it's normally it's rare, and also have inflammatory cells surrounded. So that's, but also the chromatin is kind of really fine, and nuclear contour is smooth. So this is a typical repair. You can see, also very prominent nucleoli, smooth nuclear contour, and hemp, this is a little bit streaming nuclear polarity, and you can see from this picture. And this is in atrophy, and in atrophic smear, sometimes it's kind of hard because you have enlarged, dark, hyperchromatic nuclei, but in surrounding is all typical atrophy, and you can call this atypical, but seriously, this should be interpreted as negative with atrophic pattern. So again, AS is not entity, only reserved for if you suspicious a seal lesion. Right? So how about some people saying, why we use ascus? Can we get rid of it? Just black and white. That's what our clinician prefer. You don't tell me that's ascus. I don't know what that means. This study pointed out, if we eliminate ascus, put all in negative category, you're going to miss, in this study, 13 low seal and 10 high seal. That's pretty significant. So, and again, there's a study out there, old ascus, it turned out, the follow-up will have 14% low seal, 11% high seal. So that's pretty significant. So we cannot remove this category. Management for ascus is reflex and high-risk HPV testing. And if it's negative, return to routine screening. If it's positive, is to go to colposcopy. And one exception is if it's patient really young, then cytology is preferred, and if HPV is positive, repeat at 12 months. If it's ask-age, then just go straight to colposcopy. So this is the CAP CAP guideline. We should keep those in check. So the ascus slide toward a seal ratio should be less than 3. And that's just a few numbers you can read on itself. So next category is low seal. So low seal is a definitive category diagnosis, and you have nuclear atypia. As I mentioned before, you have enlarged nuclei and irregular nuclear contour hyperchromasia. So nuclear feature is really the key. So that's a beautiful, very classic picture for cytology. You have all the nuclear features. On the right-hand corner is the histology and correlate with the cytology features. And this is another beautiful picture of low seal. And this is the one I want to point out. This is, even though they're not that coilocytic, but the nuclei really enlarged and hyperchromatic. That's the feature of low seal. This one is kind of, you don't see that much classic coilocytic change, but nuclear atypia nailed the diagnosis as low seal. So this one is keratinized low seal. So it's very large hyperchromatic nuclei. Cytoplasm is orange color, but the nuclear feature is there. This is another feature. The half is keratinized, the other half is non-keratinized. And it's just a few pictures of low seal. So low seal mimic, I want to point it out. There is a few radiation effect, left corner, the upper half, the first picture is the radiation effect. You can have nuclear enlargement, low NC ratio, but that's, is the plasma coagulation. That's all pointed out. And patient history, and combine everything. That's a radiation effect. The first line, the middle picture, that's a pseudocoidocytic site. And herpes on the right upper corner, that's herpes simplex, can mimic locio. And the lower line is just add up on each category. So the management of locio, this is according they updated, but I think it's very similar in 2022. And this is, I mentioned before, the locio will go to colposcopy. Exception is for young people, and they can use, either PAP and with testing HPV at 12 months interval. And if pregnant, is okay to defer the colposcopy to 6 weeks postpartum. If it's postmenopausal, some of our clinicians ordered HPV testing. If it's negative, they just follow up. So the next category is very important. So it's high seal. So this is the lesion we do not want to miss, because low seal, you all know, as the first couple slides I mentioned, the low seal, especially in young patients, it can go away by itself. It's transient infection. But high seal, that's precancer lesion, we don't want to miss that. So it occurs in the immature cells. Normally it's parabasal size cells, and you have either single cell pattern or hyperchromatic group pattern, is called syncytial groups. Normally they show nuclear enlargement and marked irregularity in the nuclear contour, and a very dark nuclei, and chromatin is very coarse. So I'll show you the pattern. So this is the classic pattern. It's called loose, single cell or small group. You can see the nuclei the contour is very irregular, right? And coarse chromatin, high NC ratio. Compared to low seal, it normally give you very low NC ratio. And on the right lower hand corner, that's histology. You can see the mitosis up toward to the top 1/3 layer. So that's high seal. And one important thing I highlight in the bold is, so you are not supposed to see nucleoli. So in all the seal lesion, you don't see nucleoli. Once you see nucleoli, you have to back off. That might be reactive or something else, right? So this is a small group, kind of loose, cohesive, small group of high seal lesion. You can again see the coarse chromatin, high NC ratio, and nuclear membrane is very irregular. And this is a case I scanned in, is from our institution. Is very chromatic. This is a hyperchromatic group. This is a different pattern. So you can see every single cells have irregular nuclei, high NC ratio, and dark nuclei, and enlarged. So isolated cells sometimes can be missed. Especially in the conventional smear, because they're very cellular, and or if there is exuberant inflammatory cells, it can cover and have obscuring artifact. So you have to look closely. So that's the one cell in high power. You can see very irregular nuclear contour, high NC ratio. So just sometimes you have to go high power to look for the high seal cells. And in the liquid based preparation, sometimes the hyperchromasia cannot doesn't show that well. I think in contrast in convention smear. So you can see this is the hyper a little bit hypo, but other features all there. Irregular nuclear contour, high NC ratio, and so on and so forth. So I want to also touch base on the mimickers of high seal. This is very important. So you don't call those scenario as a high seal because management is totally different. So I will touch upon several. One is immature squamous metaplasia, IUD changes, induced changes, and endocervical polyp, residual inflammatory cell, and transition cell metaplasia. So this is squamous metaplasia. It can give you a little bit hyperchromasia and can have a slightly irregular nuclear contour. But you can see this kind of the pattern is very, the chromatin is not like chunk or chromatin, is very evenly distributed chromatin. And the NC ratio is still relative not that high. Is kind of because this is immature squamous cell, so it's a little bit high, but not toward high seal, very high NC ratio. And IUD changes is very common because we have women have IUD implanted and it causes the cellular changes. So two type of cells. One is like small in the left upper corner is a small dark with very scarce cytoplasm. And also that the lower picture is having very large speculated cells. So normally those cells are just rare. And sometimes you can see nucleolus is in the lower picture. You can see prominent nucleoli there, which you don't see in the high seal. So that's two pattern of the IUD-induced changes. Endocervical polyp is notorious for the abnormality showing in the squamous cell, and those cells can be give you like kind of smudgy, kind of dark chromatin, but normally they have you're going to have like endocervical polyp biopsy, so you can correlate with histology. And those cells normally is also rare in number as well. So just keep that in mind in the differential. And digitalized stromal cells it can mimic either low seal or high seal. In the left-hand side, you can see the high NC ratio and can mimic high seal, but just check the patient history and avoid those diagnostic pitfall, right? Inflammatory cells, especially follicular cervicitis, some in the liquid base, you can see, on the right upper corner, some of the lymphocytes, probably immunoblasts can mimic the high seal, but just look at adjacent cell, you can recognize there's lymphocytes, smaller size. This is actually, lymphoid follicle there is not high seal. Another mimic is histiocytes. It's pretty, well-known high seal mimic. And you can see the conventional smear. You can also kind of like bean-shaped nuclei and irregular nuclear contour, a relative high NC ratio, but they're contrast to the real high seal on the right-hand side. the nuclei, really hyperchromatic and high NC ratio and coarse chromatin. That will help you. The pattern in the high seal, I will point it out as well. And I mentioned a small group or single cell, and also hyperchromatic crowded group is another pattern. So when the high seal involved gland, just also bear that in mind. And in atrophy or stripped nucleus, those or keratinized, keep those in mind. So this is a hyperchromatic group. Is in contrast that small single cell loosely cohesive group. This is very tight cluster, but you can see the high NC ratio nuclear hyperchromatic coarse chromatin. That's HCG pattern. So, the differential diagnosis, also keep in mind, whenever you see hyperchromatic group, keep those in mind. Either high seal can be HCG pattern or high grade, high seal involved in the cervical gland, or AIS, or benign counterpart, this benign cervical cells, lower uterine segment ocellular picture, or atrophy. So this is high seal involved gland, and it presents one is cytology image and also histology image. So you can tell flattened cell at the peripheral. That's a clue. Is a high seal involved cervical gland. This is also a kind of pitfall. So you can see the upper left corner, that's a high seal involved gland, and definitely give you a glandular appearance. And in contrast, the AIS is very feathering looking, and but for the high seal involved gland, you're going to see, in the background, single cell, single high seal, and others, small groups. That will help you. And this is again, the high seal is hyperchromatic group, but can mimic AGC. And this is again the pseudo stratification, and the small nuclei suggests a glandular involvement. This is I want to show you. This is actually lower uterus segment. Sometimes we do see in the LBP, it's very large tissue fragment, because when the brush goes very high, and they can get lower uterus segment, but the cell is very benign looking. So this is high seal in atrophy. Sometimes is kind of hard to tell, but again, the irregular nuclear contour and dark chromatin, coarse chromatin will help you. In contrast, atrophy in the right lower corner. Transitional cell metaplasia is a benign entity. It occurs normally is post-menopausal, can mimic high seal because it's appear very groovy, those cells, but they're normally a little bit spindled nuclei and have wrinkled nucleoli, but the chromatin is not that coarse and dark. In contrast, the high seal on the right-hand side. Again, as I mentioned before, for some reason, the LBP, especially thin prep, can somehow, maybe it's because the methanol fixation to make the nuclei really hypochromatic, but the other features, irregular nuclear contour, nuclear groove can help you nail it down as a high seal. So again, another mimicker is endometrial cell. So sometimes the HICU can be the nuclei can be small, not very large, so can mimic the normal EM. But you have to look around other cells, and also nuclear features is there. It's very irregular nuclear contour, coarse chromatin, and those help you. And on the right hand side, that's normal endometrial cells. So this is another real case. So it's a hyperchromatic group, crowded group. So what's your diagnosis? I'll show you a couple pictures. You probably recognize it immediately. So this is, high power, and you can see the nuclear feature toward something. And this is even obvious, right? Nuclear molding, chromatin margination, the 3M. So this is herpes. So it's a mimic. If you don't look closely in high power, you can, low power, call it HICU. So just keep that differential in your mind. The other I want to point it out is keratinized HICU. So you can have, keratinized, but the nuclear feature is similar. Nuclear hyperchromasia, high NC ratio, and in the keratinized, it's very pycnotic nuclei. So again, this is, keratinized HICU, and the cytoplasm can be a little bit more than the regular. So this is just another picture. I just want to show you a little bit more picture so you can have that in your mind. So a few words about management of HICU. So according to ASCC guideline, the HICU could be, definitely go to colposcopy. And it depends on it varies from the institution. Some of the institution just, go get biopsy and the target area, target biopsy, and confirm that's a HICU, and then go to LEAP. Recent the guideline, you can send the patient to immediate LEAP. Exception definitely, makes sense. If patient is pregnant, then you don't do the immediate LEAP. So ask age. So it just, a few cells, rare cells, but you think about that's probably suggested HICU, but, the number, the quantity and quality, not definitive for HICU. So this is a smear. You have only 3 cells. And it's not, you definitely suspicious for HICU, but it's not definitive. So you call ask age. This is another one. This is a vaginal specimen. You have only 2 cells there. You can call ask age. The last entity I'm going to go over is squamous cell carcinoma. First, it's non-keratinized. Normally, you have very large macronucleoli, and also in nuclear enlargement and very irregular chromatin. And you always see tumor diathesis. And in liquid base, one thing I want to say is subtle sometimes. It's called cleaning diathesis. You have to look closely. So those 2 pictures you can see immediately that the nucleoli just staring at you is macronucleoli, and you have high NC ratio, irregular nuclear contour, and nuclear enlargement. And this is another picture of squamous cell carcinoma non-keratinized type. So keratinized type is very striking looking as well. You can see those, cellular pleomorphism, has so-called tadpole cells, very bizarre nuclei, you can recognize immediately. So again, tadpole cells and look at the right-hand side, that nuclei is humongous. And so this is kind of like you have tadpole cell, but it's few. But in the background, you have high seal. You can say high seal with features suspicious for invasion. And by the way, this entity is in the assess system, so you can use this entity. So mimicus, and as I mentioned before, the reparative change can mimic squamous cell, and you can see on the left-hand side that's true squamous cell, all the features there, horse chromatin, micronucleoli. The repair is kind of very fine nuclear chromatin, and nuclear contour is very smooth, and you have that background reparative changes. And there is no diastasis. Pemphigus is another one. Rare. I haven't seen pemphigus. It's very rare, but keep that in your differential if you encounter. But squamous cell is you still look for those features. This is atypical repair. This is the most bizarre reparative change I've ever seen. So you got all the, the feature, very prominent nucleoli, but chromatin, again, is very fine chromatin. Regular chromatin is not like very chunk dark. And you do have prominent nucleoli. And patient probably have some history, for any vaginal intervention, cervical inflammation or something in the clinical information, and follow up on this case in a 5-year or 10-year, the patient have no cancer. So this is very striking, the most striking atypical repair I ever seen, but keep that in differential. And for diastasis, I want to point it out as well. So when you're looking for diastasis, this is true diastasis. You see the background, seal lesion, the tumor cell, characterized tumor cell, and you see the grungy background, that's tumor diastasis. But there is something, this is not. This look alike. This is in the atrophy we see all the time. You do have like atrophy induced, the background kinds of grungy material, but they're not diastasis. The nuclear feature will tell we don't see seal lesion in the background, but just keep in mind this is not tumor diastasis. And also lubricants. So we keep telling the clinician, when you don't put too much lubricant, but we do see sometimes that's smear full of the lubricant material, that grungy material, kind of purple color, they are lubricant. So they're not tumor diastasis. So in summary, so cervical cancer, we try to, screen and prevent, from the using HPV and Pap testing. So and just keep in mind this, the screening, the guideline is ever evolving. Since I practice, it's changing at least every 5 or 10 years. And reporting system, as I mentioned, the non-best system, the 4th edition is underway, and management guideline is also the new guideline and new edition will come out. The task force guideline is coming out pretty soon. So again, as I mentioned before, the cervical cancer screening, the focus is find high seal lesion. And now it's also a glandular lesion to screen, for AIS is another, but that's going to be another hour to talk about it. I'm not going to touch upon on this session. And also I present mimics and diagnostic challenges. Keep those in mind when you make diagnosis. And accuracy comes the experience. And the more you practice, then the more confident you are going to be. Thank you. Any questions?
Thank you, Dr. Liu, for this fantastic talk. And I do have a question, on the several first PowerPoint page, you talked about the low seal, and you showed several pictures of the chunk dark like chromatin.
Okay.
Yeah, for me, I feel like very hard to understand. Could you talk a little bit more about this?
Is this the picture?
Yes.
Yes. So this is so when I teach the resident, I always emphasize on nuclear features. So actually nuclear features is the key. Cholestatic change definitely is good if you see it, but half of time you don't see the cholestatic change, but the nuclear feature you can see the chromatin very coarse and hyperchromasia and irregular nuclear contour and nuclear enlargement, but low NC ratio. So those are diagnostic feature for low seal.
I have
Hopefully,
a
I
question.
answered your question.
Sometimes we don't see, or sometimes, at least in tissue diagnoses, we sometimes use the presence of atypical mitoses and things like that to distinguish something that may be L-cell kind of florid versus something that really should be called H-cell. But we don't see mitoses very frequently on pap tests or so forth. Do you ever use that, or have you used that?
No, we don't. This is in the best system. We don't use mitosis because it's very rare seen in pap smear. Maybe see once.
Yeah, it is.
Yeah, many years. It's very rare. And mostly in high seal lesion, not low seal. I never seen low seal lesion. It's high seal lesion I see. Rare mitosis. Yeah. Any other questions?
So, Dr. Liu, I have one very beginner question. So I haven't practiced. So this is the cytology. So for the regular histology, we can, use the lower power to see the pattern. But this one is cytology. So I just joined study I studied the module. I just learned so I don't know, from lower power to higher power, how to see the so many cells to identify, one or two or even less than 10 the neoplastic cells. So can you share some experience for the beginners to check the slides?
Right. So this is very, very good and very valid questions. So I normally use 10 power as a screening power. So you cannot use 4, right? In microscope, you have like 2, 4, 10, 20, and 40. So for pap smear, 10 is the best one. So you won't miss anything. If you use 4, that's too low. You're going to easily miss high seal. And high seal is the one you don't want to miss. In US, we call the high seal cell is the litigate cell.
Litigation cells.
Yeah,
Yeah.
litigation cell. That one get you in trouble, get you in the court. Yeah. If you miss a low seal, as I mentioned, it's a transient infection. It will go away, especially in young people. So low seal is okay, you miss it. You don't want to miss it, but it won't get you in the court.
Thank you.
You're welcome. In a 10 power field, if you suspicious for sorry, for high seal, then you go down to higher power, like 20 and 40, and make sure you don't miss it.
Yeah, I just have a question about Ask Edge, Dr. Liu.
Yes.
That's the category where I'm always, you're like at one end you have high cell, and then on the other end it could be just reactive. That's how. So do you have any like pearls of wisdom how to approach Ask Edge?
Yeah, that's a very good question as well. So, ask age is you use this term if you really suspicious for HISU and then it's not there yet, then you use it. So sometimes atypical squamous metaplasia in the histology, that will appear in cytology as like look like HISU, but we know, we're suspicious, but we cannot make for sure. Those kind of cell, like in those kind of case, like ask age, like I do cytohistocorrelation. I do see people call ask age. It turned out two different way. Either it's atypical squamous metaplasia, and then there's a greater percentage is HISU, turned out HISU. So just like ask age, you cannot get rid of that category. If you get rid of that category, you're going to miss low seal and high seal. I showed the slides, certain percentage. It's the similar way we cannot get rid of ask age. Otherwise, our sensitivity is going to go down. So we want to be sensitive to catch the high seal lesion. And they can go to colposcopy. If they don't see a lesion, then they closely follow up the patient. And in the majority time, it do turn out as high seal. So yeah.
Thank you.
So we have a couple of poll questions, and I'm going to go ahead and launch the poll for people to fill out.
Okay.
Give us a little bit of feedback. There are 4 questions. And so first, just to sort of see where people are. And how much of the cytology module you've completed. And your reaction to this session. And then the next question, the last question is kind of when you want to start the next round of module mentoring sessions. We have just about ready to release the GI1 module, which will be the next module that we would offer to this group. And that just finished some of the edits on that yesterday. So we'll use your suggestions to help us determine when to begin scheduling the findings. Okay, we got about almost everybody's answered the question. A few more of you need to put your answers in, and then we'll know. Along that line, those of you who are part of our new PEP trial, we really want to encourage you to move forward and finish the modules so that you can and take the final post-test. That post-test is going to be open for about another 4 weeks. So you do have some time to polish up the other modules, but even if you don't finish all the modules, please take the post-test because we know that you've worked on some of these at least, and that you're likely to have improved in those areas. So we want to get some granularity in terms of how well we've done with that, and how effective this way of learning is for you in doing that. Okay.
Can I have a question, please?
Oh yes, please, Dr. Van.
In the GI module 2, the week 3, the homework, I have to accept the link to see the slide of Johns Hopkins University, but I couldn't accept that link. I wonder, like, anyone have the issue like me, or just only me?
So we just revised the GI module a little bit, so you may have to go back and do that over. But I will check on that link. It's a link to John Hopkins slides.
Yes. Yeah, I tried to use both Wi-Fi and like 5G, but it couldn't work.
Okay.
Thank you.
So I'll share the results of our poll. We have Asia, Africa, and North America. Some of you have completed the cytology module, and some are still struggling with it. Carol, everybody loved your session, and it looks like we're kind of we have a mixture of dates to start. 8 in February and 3 in March, so we'll probably do something towards the latter portion of February for our beginning the next mentoring session. Any last questions anyone wants to bring up or ask?
I have a question.
Yes.
I tried to accept the post that, but it told me that I have to complete the Cyto 2 module, but I go to the link. I have completed that.
Okay, I'll revise that stipulation so that you can take that. I set that up trying to encourage people to finish, but we can make that adjustment